Well, thanks everybody for coming. Before I get started, as I always do, and as I think every speaker ought to do, I'll explain how I make my money. I don't see a lot of patients in practice anymore. In addition to my role as the medical director here at the Kansas Business Group on Health, I have a small consulting company called Double Arrow Metabolism. I work for an asynchronous peer-to-peer online medical consult company called Rubicon MD, and I've worked a lot for Change Healthcare, formerly known as McKesson. Before we're done here in the next 45 minutes or so, I hope everybody understands that just spending more money on healthcare is not necessarily associated with improved outcomes. There are a few possible societal benefits to excess healthcare spending, but they are few, and I think we can probably name them all, and we'll try to do that. I want everyone to identify what the three dominant sources of excess cost are in American healthcare versus our peer countries. And then finally, I want to take kind of a high level 10,000-foot view of a more policy-oriented strategy or a set of strategies to drive down cost in American healthcare. I think you'll get more granular stuff from other speakers, but we'll take a very high, almost governmental level view on what might be done about this. So I'm not going to spend a lot of time on quality because you've all probably been beaten over the head with this in the past, but just suffice it to say that the United States spends a lot more than any of our peer countries on medical care, and we don't necessarily get a return on our investment. Here you see along the x-axis healthcare expenditures per capita in 2010 dollars, and on the y-axis there, the vertical axis on the left, you see life expectancy. So what you see is the United States spends a lot more, maybe double the amount of the typical developed country on healthcare, and in spite of that, we lose the better part of a decade of life expectancy versus our peer countries. And life expectancy isn't the whole game, so you'll see a lot of different ways of ranking healthcare systems out there. And this is the Bloomberg one, which is one of the best known ones. There's one from the World Health Organization and some others. But no matter how the United States is ranked or is rated, we're always ranked somewhere in kind of the mid to low 30s. And we're down there with some kind of surprising and in some cases kind of unsavory company, right? I'm not thrilled at the fact that Cuba has potentially as good or slightly even better healthcare than we do, in spite of spending about 1/10 as much per capita as we do. I also want people to recognize that ranking healthcare is a very complicated business, right? So you'll see Italy ranked way toward the top of this. Italy's a country that traditionally struggles somewhat economically, and they were sort of the initial lead-off world canary in the coal mine for coronavirus, although they've got it under control now. So no one's perfect, but no matter how things get rated, the United States always comes up kind of dead last among developed countries in the world. So a cynic might say, in the last 100 years or so, we've added at least 40 years to life expectancy. That has to cost something. Who cares if we're spending a little extra money on healthcare to accomplish that? But I want to throw out some provocative data to you that suggests that maybe spending more on healthcare doesn't necessarily prolong life, so at least beyond a certain threshold. So what you see here, the orange boxes are Organization for Economic Cooperation and Development countries, so-called OECD. The dark boxes are the dark circles are high-income U.S. states. The open circles are low-income U.S. states. Again, along the x-axis, you see what percentage of healthcare of GDP healthcare expenditures account for, and on the y-axis on the left, you see life expectancy. And so what we see here is a very neat and tidy linear decrease in life expectancy as healthcare expenditures rise. That is, the more any given state or any given country spends on healthcare as a percentage of its gross domestic product, the less long the people in that state or country can expect to live. Now, this is strictly observational. This is not the result of any experiment, at least not any intentional experiment. So it's entirely possible, although maybe not plausible, that all the sick people in any given state or any given country are simply moving toward places that spend more money as a percentage of GDP on healthcare and driving their life expectancy down. But I think it's pretty it's pretty convincing that this could be the case, that by not spending money on other things, we're affecting people's life expectancy. That is, think of other things that make people live longer or shorter lives. Maternal literacy, for instance, is a very powerful predictor of infant mortality. And we don't typically count efforts toward literacy in things like healthcare. But if we're spending a lot of money on healthcare, at least healthcare as defined by doctors, hospitals, nurses, drugs, etc., that's money that cannot be spent on things like illiteracy prevention. So that's all I'm going to say about quality. Suffice it to say that American healthcare quality isn't what we would like for it to be, especially considering what we pay for it. But the other part of the value proposition is price, right? So people define value as this relationship between quality and price, where if price goes up, value goes down. If quality goes up, value goes up. If price goes down, value goes up, etc. It's just this ratio of quality to price. So let's spend some time talking about why it is that American healthcare seems to have such a high price. So all in all, we spend about $1 trillion more on a per capita basis on healthcare than the number 2 country in the world. The number 2 country always kind of flip-flops back and forth between Switzerland, Luxembourg, or Norway on a per capita basis. There in the red bar in the middle, you see the OECD average. And as you move to the right of the figure, the cost goes down. One thing to notice here, and we'll touch on this again in a second, is that the dark part of each bar is government spending, and the light part of each bar is private spending. And as government spending goes, the United States still spends a fair amount, but we're kind of more average in that regard. Most of our excess healthcare spending comes on the private side, which is exactly the part of healthcare spending that folks like you, employers, are responsible for. So you're getting hit especially hard in regards to this excess healthcare spending. I want to put that $3.5 trillion a year, now creeping up closer to $4 trillion a year, that we spend on healthcare in perspective. The entire United States budget is about $4.1 trillion per year, right? That's what our entire federal government spends on anything and everything altogether in any given year. Now, about 2/3 of our federal budget is Social Security, Medicare, Medicaid, and defense. So there's something to be said for any politician who gets up and says that we're not going to touch any of those, but yet we're going to trim the federal deficit. I think we have to wonder about that person's honesty or sanity. But what I'm really trying to get across here is that the 3.5 pushing $4 trillion a year that we spend on healthcare is just an enormous number. It equals what we spend as a society on almost every other, at least federal governmental program combined. And again, most of that is private. Here you see the 11, or not the 11, but 11 members of the OECD that we would consider kind of peer developed countries. And total healthcare spending is in the light bars. And you see that government healthcare spending, which is the dark bars, again, we're kind of middle of the road, nothing really extraordinary there, but private healthcare spending in the light gray bars, we kind of blow everyone else out of the water. All right, so do we get anything out of this? The fact that we spend so much more than anybody else, do we get any return on that investment? And some would say in some ways, yes. So in terms of clinical trials, the United States is by far #1 in the world. If you want to test a new drug, this is the place to do it. We're #1 by far in Nobel laureates in medicine. I think we at least double the United Kingdom, which is the #2 country in Nobel laureates in medicine. We're #1 by a pretty healthy margin in patents as it relates to medical devices and drugs and whatnot. And so as a result of that, you could say that we're probably #1 in medical innovation overall, although that assertion depends in large part on your on your definition of innovation. If you want to talk about innovative care models and whatnot, I don't think we're number one. But if you want to talk about the place to come get the newest, greatest chemotherapeutic agent, or to the place to get a face transplant, we are clearly number one. So there is some societal benefit from this excess spending, but it's limited. So why is it that we spend so much money on medicine here versus other countries? What structural things are in place that's causing this? Well, it's tempting to say that we just have worse habits. If you look around in the United States, you see a lot of smokers, you see a lot of people who are carrying around more weight than they ought to, maybe not as many people wear their seat belts as should, whatever. But I want to sort of dissuade you from the argument that we are simply worse people or have worse habits than people in our peer countries have. Here you see the rates of smoking in the United States in the blue line, smoking in other peer countries in the red line, US obesity rates in green, changes in obesity rates in other countries in purple. And you see that while we certainly have our issues with all these things, we're not really a world outlier in these things. We're I think the second most obese country in the world right now, but other countries are catching up with us. And in spite of the fact that we don't necessarily have worse habits than everyone else, we've seen this big difference in change in life expectancy over time. So along the bottom of the screen here, you see 45-year-old men and women, 65-year-old men and women, and you see their life expectancy change from 1975 to 2005, that same period of time we were looking at changes in bad habits. And you see that the other countries, mostly, again, developed Western European countries and Asian countries and whatnot, have experienced a much greater increase in life expectancy than we have, in spite of the fact that they spend far, far less on medical care than we do. So this isn't just a matter of bad habits. There's also the temptation to say that Americans are just sort of degenerate consumers of healthcare services. They're just out there, getting services that they don't necessarily need. But I don't think the data backs that up. Here you see rates of utilization of lots and lots of different services along the left side of the figure. And the countries on the left side of your screen are countries that use a lot of these services. Countries on the right side of the screen are countries that don't use so much. And the United States is, again, kind of in the middle on a lot of these things. Now, we use a lot more a lot more sectional imaging in terms of MRI and CT than a lot of countries do. We do a lot of knee replacements here and a lot of C-sections and whatnot. But, as a whole, we're not kind of huge outliers in consumption of these services. And if you look specifically at consultations and inpatient services, we suddenly become not only middling, but we're kind of the caboose of this train, right? So in hospital discharges, again, you see the mean denoted. I'm looking at the upper left part of your figure here. The mean is denoted by the vertical dashed line. We are far, far below average in terms of hospital discharges per year compared to peer countries. We are in the bottom third in hospital bed days on the lower left part of the screen. We're in the bottom third in all-cause length of stay in the hospital, lower right part of your screen, and we're in the bottom third in consultations. And that brings up a second point, which is many people point to our primary care shortage as a big problem for healthcare expenditures. And I agree. I do think primary care in this country is underserved. But if you look at our primary care population of physicians, about 43% of American doctors are primary care docs, and that happens to be exactly the average of every other country in this figure. So it may be a problem for us, but it's not a problem that explains this, right? So because if it's a problem for us, it's a problem for everyone else too, because we are exactly at the average for the number of primary care docs compared to other countries. So this is the part of the talk where I make kind of a provocative proposition that if we're going to tackle this problem, there are three big places to start. Remember, whenever you talk about cost in medical care, it kind of turns into a circular firing squad where everybody wants to shoot the person next to them. But I really think it takes tackling more than one problem at once. So the first big reason that we need to address for excess American healthcare spending is what we spend on medications, right? So we spend about 3 times what other developed countries do for drugs, and that alone accounts for almost a fifth of our excess healthcare spending. So remember that the problem in American healthcare, if I haven't already sort of laid it out, isn't consumption, it's cost. Everything that we buy costs more. So in this figure on the left side of your screen, you see different factors that could be associated with increases in spending. And you see that our population size has grown over time, so that equals a little more spending. Our population has aged a little bit, which accounts for more spending. Disease prevalence, at least the stuff that costs a lot of money, has actually gone down, and service utilization has actually gone down over time, which is something we'll talk about in a subsequent slide. But then look at service price and intensity, meaning how intense are the services provided and what do they cost, and it has gone way, way up, and that includes drugs. So our per capita drug spending in this country now approaches about $1,500 per year per person. That's versus around $700 for the other 11 countries that I just showed you in those other figures. To put that even more starkly, Americans account for a little less than 5% of the world's population, but we account for 27% of global income, so not too shabby, right? So we're a developed, rich country. But on the other hand, we account for almost 80% of global pharmaceutical profits. Our 4.5% of the world's population accounts for almost 4/5 of what any drug company makes in terms of profit any given day. I have no idea the psychology behind this. I don't know why American consumers and American taxpayers have so long been willing to kind of shoulder the load, subsidize drug spending for the rest of the world, but that's the situation we find ourselves in. So again, I'm showing you the same data that I showed you a little while ago as it relates to utilization, except now we're talking about drugs specifically. And where the last figure I showed you showed the United States sort of in the middle to top third of each one of these things, if you look at drugs, we are number one in almost everything, right? The only places where we fall out of the top spot are in public spending on drugs, in which we're last, right? Because our healthcare system puts most of the burden for buying these things on people like you, the employers, and we're low in out-of-pocket spending, at least for now, although that's shifted over time as more costs have shifted toward employees, as we'll talk about in a little while. So if you ask a drug company executive why drugs are so expensive, they will tell you that it's all because of research and development. But remember that that is, frankly, obviously untrue, right? We know most of these are publicly traded companies, and we know what they spend on R&D versus what they spend on things like advertising. And we know that their advertising budgets completely crush their R&D budgets. What you see here, that red line across the screen, that represents all the research and development money being applied to drug development worldwide. And you see that those revenue bars, the gray bars, in general, far, far exceed that. And as a result, drug companies are simply the most profitable companies in the American economy. You see that they kind of blow everybody else away in terms of gross profit, upper left part of your screen in the S&P 500. They even blow away other healthcare sectors, top right part of your screen, in gross profit. But as you work your way down these figures, you see that their net income, once you get to net income, it's not so impressive, right? So even though their gross profit is high, their net income is kind of in line with other sectors of the economy. And that's because, as you see on the bottom right part of the screen, drug companies have historically prioritized stock buybacks and dividends, ways to keep their stock price high over gross profits. So they're very good at keeping those net profits fairly low. I would argue that the primary way that drug companies keep the cost of drugs high is by being very clever with lobbying efforts at the federal level. They use regulatory capture and other strategies to keep prices high. So you see that drug companies alone account for a little over 7% of all the lobbying spent in the United States. No other industry accounts for more than 5%, not even energy. But let's not pick solely on drug companies, right? My goal here is not to turn this into some circular firing squad. My goal is to present a multifaceted view of this. So drugs have to get from the manufacturer out to the consumer in some way. And since the late 70s, early 80s, we've done this for about half of the drugs that are prescribed through pharmacy benefit managers. Pharmacy benefit managers, once upon a time, had one revenue source, right? They charge supply chain fees to manage a complex supply chain. But over time, their revenue sources have grown to include not only those supply chain fees, but also spread pricing, where they simply charge the insurance company more than they're paying the manufacturer for the drugs, and then also manufacturer rebates. And rebates have become a huge problem over the last decade or so. In 2008, the mean rebate for a drug was 10%. By 2019, that had grown to 26%. And insulin, which is kind of the standout worst case scenario of all these, the mean rebate was 66%, meaning that for any $100 one of your patients spent on, or one of your employees spent on insulin, only 44 of that was going toward the drug. The rest was going back to the PBM. And as such, the big three PBMs report revenues that are far, far greater than even the largest pharmaceutical manufacturers. As an example here, you see that in 2017, Express Scripts revenue was about $100 billion, which was about double Pfizer's revenue. Express Scripts does not manufacture or invent drugs. All they do is distribute them, right? So it's a strange system that we're working within. And we've seen some movement as a result of these perverse numbers toward things like PBMs that are going back to charging only the supply chain fees. So in addition to excess drug costs, the next big reason that American healthcare is expensive is that we simply pay our doctors, pharmacists, nurses, allied health people, whoever, a lot. We pay them a lot. They make much more money here than they do in any other developed country, and that includes me, which accounts for about 11% of that excess healthcare spending. So now, with excess drug costs plus the excess payment to doctors, nurses, et cetera, we've already accounted for about a third of our excess healthcare spending, right? So most of the excess spending in paying doctors is in surgical subspecialists. So you'll see that generalists, your internist, your family doctor, pediatrician, whatever, in this country, they make very good money. They make about $220,000 a year versus about $133,000 in other developed countries. If you look at specialists, say cardiologists, rheumatologists, et cetera, they make even better money, about $300,000 a year versus $180,000 in other countries. And I'm not showing the data here, but if you look at surgical subspecialists, so not your general surgeon, but your orthopedic surgeon, your ophthalmologist, dermatologist, urologist, et cetera, they make about 5 times as much in the United States as they would make in another peer country. And it's not just the doctors making more, nurses and other people make more as well. Here you see that nurses in this country make about 50% more than nurses in peer countries. Now, I will admit, I've heard an argument, and I'll admit these numbers might be slightly misleading because professionals of any stripe make more money here than they do in other countries. It's not, some evil doctor or nurse twirling his mustache somewhere. But it is what it is. Medical professionals just simply get paid very well here. Now, why is that? Well, in some regards, it's because we're a big, advanced, developed economy. But in another regard, it's because physicians simply get to choose their own prices here. Remember, the way that the price for any service gets set is that the American Medical Association owns a committee called the RUC, the Relative Value Scale Update Committee. They meet a few times a year, and what they do is they assign and update relative value units assigned to any procedure. So whether that procedure is removing a toenail or evaluating you for depression or doing a heart transplant, there is a code or a set of codes assigned to that, and the RUC sets the fees that are associated with those codes. So at the end of the day, they guide about 3/4 of all the physician payment in this country, a $500 billion a year or so. And the people that are assigned to this committee aren't assigned to it because of any particular altruistic bent, right? They're assigned mostly by professional societies. So the American College of Radiology assigns someone to this committee, and the American Academy of Pediatrics assigns someone, and their jobs are frankly to make sure that everyone gets paid, right? The trouble is, beyond the kind of weird last legal monopoly aspect of this, is that they often operate on kind of flawed data. Surveys go out to ask doctors how much time a specific procedure takes them and what kind of resources, but those survey results are ultimately returned by only about 2% of physicians, and they're updated as infrequently as every 20 years. So in spite of the kind of perverse incentives of the RUC and the fact that they're operating with less than perfect data, their recommendations are accepted without change by CMS about 90% of the time. CMS says, okay, you want this amount of money for this service? Done. You got it. And then the commercial insurers simply base their payments on a multiple of that CMS physician fee schedule. Finally, in this country, because of the way healthcare is paid for by lots and lots of independent, both public and private insurance companies, we have an astonishingly high level of administrative cost and complexity. And that alone accounts for about 8% of healthcare spending. So between these three, excess drug costs, excess payment to doctors, nurses, pharmacists, whoever, people working in the healthcare sphere, and this administrative complexity, we've accounted for almost 40% of the excess healthcare costs in our system, or system of systems, as some would say. So why do we have such high administrative complexity? And isn't this just waste? After all, as Don Berwick and lots of others have pointed out, our system is so big and so expensive that our annual waste probably equals or exceeds the entire CMS budget every year. Well, waste is generally put into 6 domains in medicine. One is failure of care delivery. That's just when you get bad care at your doctor's office or at the hospital, failure to adopt best practices for any given condition. Second is failure of care coordination. That means you go to the hospital, get discharged, you don't get some critical piece of equipment when you get home, like your oxygen or your CPAP or wound care equipment or something, and you end up back in the ER or readmitted just to take care of that bad care coordination. Third is overtreatment or low value care. So if you're someone who's ever gone to the doctor for an upper respiratory tract infection and demanded antibiotics, you're some tiny part of this problem. It's us treating things that don't need to be treated, or providing care that just is hard to prove a return on investment for. Fourth is pricing failure, which kind of goes through all these and a lot of the things that we've already talked about, but that's basically the failure to set value-based prices for things like imaging, testing, drugs, etc. Fraud and abuse speaks for itself, but then there's this administrative complexity. So administrative complexity is only one domain within this larger umbrella of waste, but it is by far the biggest of all of them. And so here's a figure looking at administrative costs over time. And you can see there's not really any one event that drives up healthcare spending. I've tagged a couple of, or several landmark healthcare laws here: diagnosis related groups back in the early 80s, HIPAA in the mid 90s, HITECH 2009. And you see that in spite of all those, or maybe because of them, but not in any neat and tidy way, administrative expenses just inexorably rise over time. So now we're stuck in this spot where 8% of our total healthcare total healthcare money is spent on overhead alone, which is triple what is spent in Canada, where, you know, the Canadian system is just different. They have one insurance company that pays for everything, so everyone operates under a unified set of rules. And so under that observation, if you look at private insurance related activities, our overhead goes to 14%. And that's because every insurance company has its own set of rules that has to be followed. So, so every doctor that you see has a small crew of people working behind her, just working to submit bills. So if you look at the 10 other countries in that 11 country group that we've been talking about through this talk, they have an average of about 3% overhead. And not all those countries are single payer like Canada. Many are just much more regulated insurance-based models like we have. So if you break this down per encounter, you can see that whenever you go see the primary care doctor, $20 is taken off the top of whatever you are charged strictly to submit the bill. That $20 is the cost to that doctor to have someone gather up all the paperwork and send in the bill. In the ER, it's about $60. For a general inpatient stay, it's about $124. If you have an outpatient surgery, it's $170. Inpatient surgery, $215. So this is the cost of submitting the bill to the doctor or to the system. The sadder part of this is that, as with many things in medicine, this system is specifically designed to punish primary care doctors. So if we take the ER and primary care doctors, which are kind of the backbone of our system, especially the primary care folks, they pay more as a percentage of the visit for the cost of billing than anyone else. So not only do they make less money overall, but it costs more for them simply to submit the bill. It's not simply a matter of what it costs to submit the bill, though. If you've ever received one of the kind of nightmarish copied and pasted and hard to read and gobbledygook notes from your doctor's office or from a hospital stay, understand that a lot of that language is in there strictly for the sake of billing. So what you see on this figure to the left of that red line is the number of characters included in an average outpatient note in other peer countries that you see listed along the bottom of the figure. So pretty short notes. If you go to the National Health Service in the UK, for instance, the doctor's notes tend to be just an assessment and plan, very, very short. But everything to the right of that note is the number of characters in random notes from American ambulatory visits. So you can see that the average American note is about written by the doctor, is about 4 times the length of a note written by someone in another country. And that is, all that text is there to support billing for the most part. It's not to help out a subsequent doctor. It's not all there to record what happened in that visit. It's just there to bill. And one of the unfortunate effects of the ACA was that in trying to promote the merger of healthcare systems to hopefully drive down administrative costs, what the law accidentally did was just give, you know, give each healthcare system more negotiating power. So if you took two moderate-sized healthcare systems and combined them into one giant integrated healthcare system, it just gave them more negotiating power with insurance companies. So whatever administrative complexity was lost in that merger was more than made up for by more hard-nosed negotiation, so that we've, I think, pretty definitively shown that these large integrated healthcare systems are more expensive on the private, I'm sorry, on the private side than their predecessors were. And then finally, remember, about half the insurance sold in this country is sold through a broker. Most of those brokers, not all, but most of them still operate under a commission model. So the more that broker can get you to spend on your healthcare benefits, the more money they are going to make. So there's almost no incentive for that broker to save you money. Now, over the last few years, we've seen the rise of a lot of cash payment brokers, brokers that don't have, brokers that disclose all their revenue sources up front, et cetera. And so this problem may be taking care of itself. And we'll talk about it a little more in just a bit. But over time, understand that it's widely recognized that brokers have been a part of this problem in terms of driving up healthcare costs on the administrative side. So imagine that you're crowned the emperor of healthcare for the day. So from a governmental standpoint, how would you increase value, either by increasing quality or decreasing price? Well, to address that question, we all just have to remember that the expense of any healthcare service is a matter of the cost times the volume. So if you want to decrease the cost, you either have to decrease the price of the service or you have to decrease the volume of the service. And no matter what you do, no matter what your approach is, the end result has to affect one of those two or both. So in spite of good data that shows that Americans are not excess healthcare utilizers, companies have mostly leaned on employee cost sharing as their primary strategy. About 60% of companies or so have gone toward things like high deductible healthcare plans and whatnot. With the intention of driving down healthcare utilization, in spite of the fact that we know that Americans don't overconsume healthcare. So instead of doing that, what strategies maybe should we follow, at least on a high level policy level? So let's talk about drug costs first. How do we fix this? Well, as you can imagine, lots and lots of potential solutions have been thrown out. One is to simply make pharmaceutical trade easier, make it easier to buy drugs here from the United States or Mexico or other places where they're cheaper. People who promote this will readily say that this is a workaround of desperation, right? Because there's no reason that we shouldn't be able to produce cheaper, especially generic drugs within our own borders. But for now, the cheapest place to get those is from other countries, but it's just very hard to do on an administrative level. Next is that we should allow direct negotiation between CMS, that's Medicare and Medicaid, and drug manufacturers. So remember, CMS is forbidden by law from negotiating drug prices on its own. It has to do any negotiation it does through a pharmacy benefit manager, and you've seen the data on pharmacy benefit managers and what they do to drug prices. Contrast that to the Veterans Administration system, who pays relatively pennies for drugs because the VA simply negotiates its own prices. Physicians at the VA have an alert that comes up whenever they prescribe a drug that tells them what it's going to cost. And I've been a VA physician in the past. I can tell you the alerts are comically low compared to what I know people on the private side are paying for those same drugs. So the thought is that by allowing CMS to negotiate, we would drive down the cost of drugs for everyone, even on the private side. Third is to institute value-based payments for drugs. So if you invent a new chemotherapeutic agent that prolongs the life of a patient by 90 days, we shouldn't necessarily be paying $500,000 for a course of that drug, right? Because the actuaries can tell you roughly what 90 days of a human life is worth on from an insurance standpoint. So the cost of that drug should more closely align with the value that it's providing, which they don't at all right now. The second big issue that we talked about before is that we pay doctors, nurses, pharmacists, et cetera, a lot of money in this country. So how do we get around that? Well, the people who have thought deeply about this think that we ought to just fund more residency positions, with the idea, especially in primary care, with the idea that if you flood the market with providers, there will eventually be no choice but for those providers to start competing on cost to some extent. Similarly, they say that we ought to eliminate hurdles for foreign medical graduates. It's very hard to become a practicing American physician. In my intern class, I had a guy who had been a practicing cardiologist in Australia, but came to the States and had to start over as an intern. So it's a very high hurdle for people to clear. And by allowing foreign medical grads to come in and work sooner, we would theoretically, again, put more doctors in the market and eventually force prices down. Similarly, they say we should fund fewer specialist positions, especially surgical subspecialists, because that's where a lot of the excess cost comes from. And there are some of those procedures that could be handled by lower level providers. And as such, we should enforce rules that doctors cannot be paid for simple procedures. So it's simple is in the eye of the beholder, but as an example, if you go to certain healthcare systems in this country for colon cancer screening, it's not a doctor that's doing the colon cancer screening in the form of a colonoscopy. It's not a nurse practitioner. It's not a physician's assistant. It's an RN. It's an RN doing the screening. And those systems have shown that they are just as good as physicians in cancer detection rates. And I'm not picking on the gastroenterologists or surgeons or anyone here. It's just illustrative of a bigger problem that a lot of doctors get by doing procedures and getting paid well for them when those procedures could be handled by lower level providers making less money. And then finally, to throw a bone to the doctors here, there's a lot of movement, or maybe not movement, but opinion in favor of settling malpractice claims by referencing standards of care in other countries. So if you failed to order an MRI here and missed a case of pituitary cancer, you could point to the standard of care in, say, Norway, and say there is no way that the Norwegian healthcare system would have paid for an MRI in this case. And so this is simply someone who fell outside the normal, usual care model and had an unfortunate outcome, as an example. And then finally, administrative cost and complexity, which is unsurprisingly kind of the hardest of all three of these to fix, but lots of solutions have been thrown out. One is to simply eliminate certain administrative burdens, particularly pharmacy benefit managers. So the argument is that once upon a time, logistical considerations and distribution of drugs was very, very difficult. But we live in a computerized age where a lot of the services that are being provided by PBMs could theoretically be provided by an automated system. We should reverse consolidation in healthcare systems by invoking antitrust laws. Again, I showed you in a previous slide that this was one of the kind of strange outcomes of the Affordable Care Act, was that it explicitly promoted consolidation of healthcare systems, but it ended up giving them so much negotiating power that they drove up the cost of care. But in terms of eliminating administrative stuff in the classical sense, it's much harder. So here you see those 6 domains of of healthcare waste. And along the right side of this is from a systematic review in JAMA a year or two ago. Along the right side, you see the potential savings from different interventions that have been described in the literature. So there are billions and billions of savings all told there. But when you work your way to the bottom of this screen and see administrative complexity, you see a simple not applicable, meaning the authors of this study could not find a single well-conducted trial that was explicitly intended to address administrative complexity in the classic sense, in terms of how complicated it is to submit a bill, how long doctor's notes have to be, etc. So we've just not really had a good way, we've not really come up with a good way to tackle this problem yet. One thing that has been percolating through the government is the idea that all health benefits brokers should have to disclose all the perks and fees that they're getting from insurance companies. Doesn't mean they have to go away, it just means they have to disclose them to you. And this has some high-powered backers, right, including our own Michael Thompson, President and CEO of the National Alliance. So one of the things that I have to confront whenever I give this talk is that I am potentially part of the problem here. And if you're listening to this talk, there is a chance that you may be part of the problem too, depending on what you do. It doesn't mean that any of us are doing bad work or that we're doing invalid work, but we just have to own up to the fact that there is probably some part of our job that is contributing to this problem. So what you're looking at here is a picture of Guildhall. This is arguably the birthplace of the modern labor union in London. And it goes along with this quote from Upton Sinclair, who said that it's difficult to get someone to understand something when his salary depends on him not understanding it. So what I always remind the medical students of when I give this talk is that they are not members of a guild. They are not tradesmen or tradeswomen who are out to protect the other members of the guild. Their job is to protect the patients that they are charged with caring for. And so as we look for solutions to these problems, I hope we can look beyond simply preserving our own incomes and look toward really fixing the problem. So with that, I'll stop. There is my contact information. You can also reach me through the Kansas Business Group on Health. I hope this was helpful. Thanks.